Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotations and you are more confident in caring for the critically ill patients. Let's talk about what you need to know for your first day of ICU rotation. If you don't have much experience in ICU, it can be a scary experience. Patients are very sick. There's generally a lot of big machines in the patient's room. There is a lot of complex information available about the patient. But don't worry, with some simple preparation, your ICU rotation can be way less stressful and way more enjoyable. Let's understand some basics of ICU. We will go over the following topics today. We will look at the reasons for admission to ICU. We will develop a systematic approach to an unstable patient. We will familiarize ourselves with the ICU environment. We will look at how to best prepare for rounds and present a patient. We will look at some commonly done procedures in the ICU. And finally, we will look at the role of point of care ultrasound in ICU. Let's look at some reasons why patients need admission to ICU. The most important reason is a sick patient who is needing advanced level of supportive care. For example, need for mechanical ventilation or need for use of vasopressors like norepinephrine. Sometimes, even though the patient is not actually needing advanced level of supportive care, they may still need to be transferred when there is an anticipated need. For example, take a patient who is admitted to floor with pneumonia, has rapidly escalating oxygen needs. The floor team may contact ICU for transfer so that patient can be observed and transferred back to floor after the condition stabilizes. Next, frequent monitoring. Take, for example, diabetic ketoacidosis or severe symptomatic hyponatremia. In these situations, labs need to be drawn at least once every hour or sometimes more frequently. The nurse to patient ratio is also an important consideration here. In ICU, each nurse has one or two patients, whereas on the floor, each nurse may have four or up to eight patients. Finally, hospitals may have policies about certain diagnosis or conditions that they must be managed in ICU. Examples would be diabetic ketoacidosis, non invasive ventilation, etc. What makes a patient sick enough to be in the ICU? Let's understand that. In a healthy state, there is homeostasis, there is normal physiology. But when there is disease process, for example, pneumonia, physiology gets deranged. Let's say there is pneumonia affecting right upper lobe of the lung. The lungs may early on still be able to compensate. The remaining of the lung is still normal and they may able to maintain normal levels of oxygen and carbon dioxide. But as the disease process worsens, as more and more lung is being involved with pneumonia, the compensatory mechanisms get overwhelmed and we may start seeing signs of organ dysfunction. So the oxygen levels may start to drop as pneumonia gets worse. Early on in the disease process, this is easily corrected. For example, low oxygen may be easily corrected to normal levels with a nasal cannula. But as the disease process continues to get worse, we start seeing signs of severe organ dysfunction or failure. In such advanced stage, patients need high level of supportive care. For example, invasive mechanical ventilation. Let's understand what makes supportive care advanced. Let's look at some features. Usually it is invasive. For example, mechanical ventilation needs placement of an endotracheal tube. The equipment is complex. Mechanical ventilator, for example, is a much more complex equipment compared to something more simple like a nasal cannula. It requires expertise for maintenance. For example, we need a respiratory therapist to maintain the ventilator. We need a perfusionist to maintain the ECMO setup. There's obviously a lot of cost involved, not only to maintain the equipment, but also for the personnel involved. Support needs to be closely titrated. For example, let's say we have a patient on norepinephrine for shock. If the patient's blood pressure is dropping, then we need to immediately titrate the norepinephrine to maintain the blood pressure. It cannot wait for minutes or hours. We have to immediately adjust the support. Same goes for adjusting the ventilator support for oxygen levels. Advanced supportive care itself comes with a lot of serious adverse effects if not properly managed. For example, high levels or high doses and prolonged infusions of vasoactive agents can be associated with serious arrhythmias. Ventilator can come with serious adverse effects as well, like barotrauma. If a patient on the ventilator accidentally extubates, accidentally pulls the endotracheal tube out, it can have fatal consequences. So it has to be very closely monitored. Because of all these features, such advanced level of supportive care must be provided in a unique environment like the ICU. For a beginner level, focus on supportive care for two very important conditions: shock and respiratory failure. Let's look at the details. There are several forms of supportive care available for respiratory failure. Patients who are on mechanical ventilators must be managed in ICU, and depending on the hospital policy, patients who are needing non invasive ventilation and high flow oxygen support may or may not need admission to ICU. Lesser forms of support are usually managed in the floor. Supportive care for shock broadly includes two categories: medications and mechanical circulatory support. There are several medications available for management of shock. These medications have varying combinations of inotropic, chronotropic, and vasoconstrictor properties. I made a separate video talking about shock. I highly recommend that you check it out. The details of these medications were discussed there. Link will be provided in the description. Mechanical circulatory support is commonly used in cardiovascular ICU. Commonly used devices are intra-aortic balloon pump, Impella, and ECMO, which stands for extracorporeal membrane oxygenation. Tandem heart is not commonly used. Let's talk a little bit more about ECMO. There are two types of ECMO: veno-venous, in which venous blood goes through an oxygenator and another chamber where carbon dioxide is removed, and this oxygen rich blood is put back into the venous circulation. That goes through the heart, which pumps it to the rest of the body. So, veno-venous ECMO is replacing the function of the lungs. Veno-arterial ECMO, on the other hand, works differently. Venous blood goes through the same oxygenator and another chamber where carbon dioxide is removed, but using an external pump, it is actively put back into the arterial circulation. So, veno-arterial ECMO is replacing the function of not only the lungs but also the heart. So, VA ECMO is really the ultimate form of support that you may see in the ICU. But like I said before, these devices are commonly used in the cardiovascular ICU and rarely in the medical ICU. Let's look at a couple of other commonly used forms of supportive care in ICU. First, the targeted temperature management. This is commonly done in post cardiac arrest patients. The machine you are seeing on the screen or a similar device is attached to the patient either via external blankets and wraps or via an endovascular catheter. The device continuously monitors patient's temperature and adjusts it to make sure that it doesn't go beyond the number that we set. This form of treatment has been shown to improve survival and neurological outcomes in certain post cardiac arrest patients. The other commonly used form of support is CRRT, or continuous renal replacement therapy. Compared to regular dialysis, which is completed in 4 hours, CRRT is run continuously 24 hours a day because it is much less efficient compared to a regular dialysis process. However, it has one main advantage compared to regular dialysis, which is it causes less hemodynamic instability. Regular dialysis can lead to hypotension because we are removing the blood through a catheter, it's going through the dialysis machine, and then we are putting it back in. So that can lead to hypotension, especially in a patient who's already in shock. With CRRT, that risk is very minimal. So, in a patient who is hypotensive on vasopressors, CRRT is the mode of choice for dialysis. Let's say we have a patient admitted to medicine floor for infective endocarditis. Throughout the day, patient had worsening mental status, soft borderline blood pressures, and needed multiple fluid boluses, had increasing oxygen needs, and sometime in the middle of night, patient was found to be unresponsive by the nurse. You were paged to evaluate this patient. You enter the room, there's obviously a sick patient in front of you, you're surrounded by 10 people, There's nurses, there's techs, there's students, there are patients' family members, all waiting to see what you want to do next. This can be a pretty scary situation, right? But don't worry, I'm going to outline some simple steps you can follow in situations like this. Let's go back to our severity illness spectrum. We have seen that as the disease process worsens, ultimately there will be organ failure. What happens if the disease process continues to get worse? Usually, it starts out as a single organ failure, for example, pneumonia leading to respiratory failure. But as it continues to get worse, there can be multi organ failure. Pneumonia can evolve into severe sepsis and septic shock, which leads to hypoperfusion of multiple organs and multi organ failure. What happens if there is multi-organ failure and disease process still continues to get worse? Ultimately, this is going to culminate in cardiac arrest. For example, in this particular case, pneumonia complicated by septic shock, there can be myocardial dysfunction from sepsis. Due to respiratory failure, there can be hypoxemia and hypercapnia, both of which lead to further cardiac instability. There can also be renal failure, which can lead to hyperkalemia, metabolic acidosis, all of which can cause mechanical and electrical instability of the heart, ultimately leading to cardiac arrest, after which, if the patient doesn't make it, they will die. The most critical point in this chain of events is cardiac arrest, because obviously after death there is nothing medically to do. So cardiac arrest is the highest form of emergency that you can ever find yourself in. So start there. The first thing to do in any emergency is to make sure patient has a pulse. There's two ways of doing it. First, call out the patient's name or move their shoulder. See if they are waking up and responding. If they are, they must have a pulse. But if there's absolutely no response, check their pulse. I recommend feeling carotid pulse, not peripheral ones. If the patient doesn't have a pulse, then you have to immediately start CPR. You have to immediately implement the BLS and ACLS protocols. Let's say you check for pulse and patient has a pulse. Then you move on to step 2, which is ABCs: airways, breathing, and circulation. This is very important. So start by assessing the airways. See if there's any obvious obstruction of the airways. Is there any swelling? Is there any significant bleeding or any secretions blocking the airway? It's very important to relieve the obstruction and, if needed, secure the airway by placing an endotracheal tube. Next, look for breathing. Look for bilateral chest movements, listen for breath sounds. If the patient is not breathing, then support has to be provided. We'll discuss the details later. Then also look for circulation. If the patient has a pulse, make sure patient has adequate blood pressure. So measuring the vitals goes hand in hand with ABCs. Heart rate and blood pressure are important for circulation. Respiratory rate and SpO2 are important for, A and B. Let's say patient has stable vitals. At this point, you can relax and move on to step 3. You have two roles in step 3. First is systematically assess each organ system and identify any signs of organ failure and provide appropriate supportive care. The other part of step 3 is to identify the underlying cause of the disease and treat it. For step 1, it is very important to be familiar with BLS and ACLS algorithms. Until you get familiar, I recommend that you carry these cards in your pocket during your ICU rotation. These are available online for free. The other two very useful algorithms are the tachycardia and bradycardia algorithms. Sometimes, even if the patient has a pulse, there may not be adequate cardiac output when there is extreme tachycardia or bradycardia. So, if there is bradycardia associated with shock, we have to consider using agents like atropine or chronotropic agents like dopamine or epinephrine, and also consider interventions like pacing. In a patient with extreme tachycardia leading to hemodynamic instability, synchronized cardioversion has to be considered. It may be useful to print these out and post them in your conference room or carry these printouts with you or pocket cards during your ICU rotations. Like we discussed, in an unstable patient who does have a pulse, ABCs are very, very important. Always assess airways, make sure there's no obvious obstruction or secretions. In certain situations like angioedema or anaphylaxis, where there is airway swelling, we'll have to immediately intubate the patient. If the patient is not breathing, start bag mask ventilation and consider more long term support like non invasive ventilation or invasive mechanical ventilation as appropriate. Then assess circulation. In a patient who has pulse but is hypotensive and hypoperfusing, appropriate supportive care for shock must be provided. Once patients' vitals are stabilized, we have two important rules. We have to provide supportive care and we have to identify and treat the underlying cause. We already talked about supportive care for heart and lungs in the form of shock and respiratory failure, respectively. Same template can be applied for any other organ. For example, kidneys. If there is AKI and hyperkalemia, which is associated with ECG changes, then it must be immediately treated with intravenous calcium, insulin D50, Kayexalate, loop diuretic, etc. as appropriate. Then we will also have to look into the underlying cause of the AKI and treat it. There can be several causes of AKI. It can be from hypoperfusion to the kidneys, it can be from acute tubular necrosis, it can be from hepatorenal syndrome, and so on. While providing supportive care is often the more urgent intervention, there are certain conditions where timely diagnosis and management is critical. In a rapidly deteriorating patient, if the cause of deterioration is not immediately clear, go through the 5 H's and 5 T's: hypovolemia, hypoxia, hypo or hyperkalemia, H plus, which is for acidosis, hypothermia. The 5 T's are toxins, including drug overdose, tension pneumothorax, tamponade, and thrombus. Thrombus in the heart, which can be in the form of MI if it involves the heart, or in the form of PE if it involves the lungs. Some basic workup can help with rapid identification of some of these conditions and must be considered in critically ill patients. This includes CBC with differential electrolytes, creatinine, troponin, lactate, blood gas, chest X-ray, ECG, and POCUS. Now let's familiarize ourselves with the ICU environment. Starting with the monitor, this is one of the most important screens to look at and gives us wealth of information about patient's condition. Let's start at the top. We see a continuous display of patient's heart rate, and we also see the rhythm being continuously displayed. So this is good not only for understanding the heart rate but also to detect rhythm problems. Keep in mind this is not voltage calibrated, so this is not a great tool for detecting ST changes. So if they are suspected, always get 12 lead ECG. Moving on to SpO2. Along with the number, also pay attention to the plethysmograph. For SpO2 to be reliable, it has to be able to pick up the pulse and ideally even show the dichrotic notch with each pulse. Next, if the patient has an arterial line, their blood pressure is continuously displayed. The other important piece of information is patient's respiratory rate. Their temperature is also continuously displayed. And depending on the patient and depending on the tools available, other forms of data like the central venous pressure, the end-tidal carbon dioxide, those things may also be displayed. You will also see infusion pumps in ICU. These are not exclusive to ICU, they are also used in other areas of the hospital like medicine floor. Basically, infusion pumps are used when a continuously infusing medication needs fine titration in dosing. Two continuous infusions that are commonly used in the ICU are vasopressors and sedatives. Of course, there can be multiple other continuously infusing fluids, but these are not unique to the ICU environment. Again, the two unique medications are sedatives and vasopressors. The commonly used sedatives and vasopressors are listed on the screen. I have made a separate video talking about the role of sedation and all these sedatives. I highly recommend that you watch that video. Link will be in the description. Also, vasopressors were discussed in the lecture on shock. Link will be in the description. The ventilator is one of the most important machines in the patient room. Mechanical ventilation is a broad topic, and I have made a separate video where I discussed in detail everything about mechanical ventilation. That is something I recommend you watch. Link will be in the description. I will summarize some key points here. Know the indications for intubation. Broadly, there are 4 reasons for intubation. One is respiratory failure. 2 is impending airway collapse. Examples would be angioedema, anaphylaxis. Third would be loss of airway protection in a patient with GCS of less than 8. Fourth is for general anesthesia. Common modes of mechanical ventilation are volume control, pressure control, synchronized intermittent mandatory ventilation, and pressure support. On the ventilator screen, mode is shown on the top left corner of the screen. Usually, settings are shown in the horizontal bottom part of the screen, and interactions are shown in the middle part of the screen. Pay attention to the ventilator pressures, which are typically displayed on the vertical part of the screen. Volume control is generally the initial mode of choice, and once the patient is improving, once the patient is awake enough to take his or her own breaths, patients are typically switched to pressure support mode. Keep in mind that FiO2 and PEEP control oxygenation, and respiratory rate and tidal volume control CO2 removal. So, if we are treating patient for hypercapnic respiratory failure, the settings we must be focusing on are respiratory rate and tidal volume. Every day, it is important to assess whether the patient is ready for extubation. There are several criteria used to assess the readiness. Some important ones to keep in mind are: the patient must be spontaneously breathing, must be needing minimal support in the form of FiO2 less than 40, PEEP of less than 8, and the original indication for intubation must be reversed or should be improving. If patient meets criteria for extubation, they must be extubated at the earliest convenience. ICU patients are generally complicated and there is a lot of information available about them. It can be a little challenging to organize the data and present for rounds. To make it easy, I recommend a systems based approach. Start with why the patient is admitted to ICU. This will help you focus on the most life threatening aspect of patient's illness. Then talk about the history of present illness and then move on to systems based assessment and plan. For each system, think about two things: one, the supportive care, and two, the problem list based plan. This is in contrast to the traditional format where we start with chief complaint, go to HPI, then talk about other history, do vitals, physical exam, review the investigations, and then talk about assessment and plan, which is problem list based. Let's see why the systems based approach is better. In the traditional format, we start with chief complaint. Let's take an example: a patient who is admitted for alcohol intoxication. We talk about history of present illness. Here, this is a 48-year-old male, history of decompensated alcoholic cirrhosis and recurrent admissions for alcohol intoxication or alcohol withdrawal syndrome. He was found down by his friend, was noted to be inebriated in the ER. He was belligerent and trying to get out of the bed, was at risk for self-harm, so he was admitted for close monitoring for alcohol withdrawal. Through the course, there were multiple complications. Patient had aspiration pneumonitis and developed sepsis from spontaneous bacterial peritonitis. He also developed acute kidney injury, which was presumed to be from hepatorenal syndrome. Later, he was noted to be still encephalopathic, developed atrial fibrillation with rapid ventricular response, and had to be transferred to ICU for progressive hypotension and shock. He also had escalating needs of oxygen and was ultimately placed on high flow oxygen. In the traditional format, we talk about past history, then we go to vitals and physical examination. Here, the patient's heart rate is 124, blood pressure is 76 by 42, respiratory rate is okay, oxygen saturation is 92%, and temperature is slightly low. On physical exam, you can see the findings on the screen. Then we talk about ins and outs, urine output, and we go through all their lab work and other investigations. Then we talk about assessment and plan based on their problem list, which is alcohol withdrawal, sepsis from spontaneous bacterial peritonitis, aspiration pneumonitis, hepatorenal syndrome, and shock. But here is the problem with this kind of presentation. What is the most life threatening part of patient's illness at this point? If you go back to our basics, step one is to make sure patient has a pulse. Here the patient has a pulse. Step two is ABCs and vitals. So there is something wrong with the vitals. Patient is hypotensive and tachycardic. That is very important. In a patient who is unstable, that needs to be addressed right away. In the traditional format, we discuss information in a particular sequence. The problem with this sequence is that relevant information is scattered all over the place. For this particular case, the patient is in shock. History of heart failure with reduced ejection fraction is important to know. Heart rate and blood pressure are important to know. The fact that patient has JVD, bibasal inspiratory crackles, and pitting pedal edema is important to know. Tells me the preload is elevated. The fact that patient has cold extremities is important to know. It goes with a vasoconstricted state, which can go with cardiogenic shock. Patient's urine output and lactate are important to know to understand how the patient's perfusion status is. And then ECG and echo are also important pieces of information. So, when data is presented in this way, it can get very confusing as relevant pieces of information is scattered all over the place between irrelevant or less relevant pieces of information. That's why systems based approach is much better. Start with why the patient is in ICU. In this particular example, patient was transferred for circulatory shock needing levofed or norepinephrine infusion. So that'll help us focus on the most important part or the most life-threatening aspect of patient's illness. History of present illness is pretty much the same. Then we can talk about systems based assessment and plan. For each system, the first part should focus on supportive care. In this particular example, I would present it in this manner. Patient is hypotensive and tachycardic based on these vitals, is in cardiogenic shock based on my physical exam, which includes JVD, bibasal crackles, bilateral pedal edema, and cold extremities. My point of care ultrasound exam revealed poor LV systolic function with a dilated non collapsible IVC. Patient's hourly urine output is poor and lactate is going up. Then we can talk about the plan. Since the patient is in cardiogenic shock with poor perfusion status, we need to optimize the shock. Plan is we are starting Lasix drip and we are adding dobutamine to norepinephrine infusion. Then move on to problem list based assessment and plan. In this particular case, patient is in cardiogenic shock, has a history of alcoholic cardiomyopathy, which was likely decompensated by atrial fibrillation with RVR. Other pertinent information, we reviewed the ECG, troponins, and echocardiogram. There is no evidence of active cardiac ischemia. We are going to start guideline directed medical therapy when the blood pressure is more stable, and for AFib with RVR, we are going to start amiodarone for rate control. Here is the template I recommend my students and residents to use. Feel free to take a screenshot or pause the video and review it. There are certain procedures that you will commonly see being done in the ICU. Let's look at each of those. Placement of a central venous line or central venous catheter is one of the most important and most commonly performed procedures in the ICU. There are several indications for central venous line placement. Probably the most common reason is administration of caustic medications. These are medications which, if extravasate through a peripheral line, can cause tissue injury. Common examples are vasopressors. Other examples are concentrated fluids like D10 or D20, hypertonic saline, etc. Another indication is need for reliable venous access. There are certain patients who tend to be hard sticks, meaning it's difficult to place peripheral venous catheter, or the peripheral venous lines may keep falling off. So when we need a reliable access, we have to go for central venous catheter in these situations. Another common indication is dialysis. Acute kidney injury and renal failures are common in ICU. When these patients need urgent dialysis, we have to place a special dialysis catheter through a central vein so that dialysis can happen. Rarely, a central line is also placed for hemodynamic monitoring. Using an internal jugular central venous line, we can monitor central venous pressure, which can be used as a surrogate for preload. There are several sites for placement of central venous line. Most common location is internal jugular. Other locations are subclavian and femoral. A peripherally inserted central catheter is technically a central line. It is usually placed by interventional radiology in patients where there is anticipated need for prolonged need for central line. Common example would be need for prolonged antibiotic infusions. Another commonly done procedure in ICU is placement of arterial catheter. This is frequently done in hypotensive patients so that blood pressure can be accurately monitored and medications can be accurately titrated. It is also placed in patients where there is frequent need for blood gas analysis, for example, in a patient in whom pulse oximeter data is unreliable. Endotracheal intubation is very important procedure. Indications for intubation are respiratory failure, loss of airway protection. GCS score of less than 8 has been traditionally considered as a surrogate for loss of airway protection, impending airway compromise. Examples would be angioedema, anaphylaxis, and for general anesthesia for medical and surgical procedures. Chest tube is placed for pneumothorax and pleural effusion, and there are a bunch of other procedures, but these are not really exclusive to ICU. Chest x-ray has an important role when it comes to procedures because we use it for verification of several procedures that we do. The tip of the central venous catheter must be ending just below the level of carina because the tip is supposed to be at the junction of SVC and right atrium. The tip of the endotracheal tube must be ending 3 to 7 centimeters above the carina. A rough eyeball test is if the tip ends somewhere between the heads of the clavicles or slightly below it, it's appropriate location. Make sure the tube is not too deep, it's not in the right main stem, or it's not just abutting the carina. And it also shouldn't be too high either. Chest tube verification can also be done with a chest x-ray. Let's say the chest tube was placed for right pneumothorax. Then we need to make sure that the tip of the chest tube is ending inside the thorax. Sometimes you'll see that the chest tube is ending just in the subcutaneous space. So obviously in that case, we'll have to repeat the procedure. It can also be used to look for complications. Pneumothorax can be a complication of central venous line placement. So we can look for that. Or sometimes the feeding tube can be inadvertently placed into the trachea. We need to make sure that the feeding tube, either orogastric or nasogastric, is going below the diaphragms and ending in the stomach to make sure that it's not in the lungs. The use of point of care ultrasound has exponentially increased in the ICU over last several years. POCUS has several important roles in ICU. Use of ultrasound for placement of central venous line is considered standard of care. It is also commonly used for other procedures like arterial line, thoracentesis, chest tube, and paracentesis. POCUS evaluation can give a wealth of diagnostic information. Understanding LV systolic function and preload are crucial to understand the mechanism of shock. Identifying RV dysfunction and venous exam of the lower extremities are useful in a patient suspected of having pulmonary embolism. Pericardial effusion can be directly visualized using ultrasound, and tamponade can be diagnosed. Using lung ultrasound, pneumothorax can be diagnosed, and any alveolar filling processes like pulmonary edema, pneumonia, pneumonitis, all of these can be identified. Pleural effusion can be easily visualized with POCUS. Identification of free fluid in the abdomen can be of vital importance in a patient with trauma. It can help with diagnosis of ascites in cirrhotic patients. It can also help with diagnosing hydronephrosis, which can be a cause of urinary tract infection or AKI. If your ICU has POCUS available, I highly recommend that you learn how to use it and use it regularly to assess your patient. Here is a quick summary of the things to know for day 1 of ICU rotation. Understand the reasons for admission to ICU. Know that the most important indication is need for advanced level of supportive care. Develop a systematic approach to an unstable patient. In any emergent situation, remember step 1 is to make sure patient has a pulse, and step 2 is ABCs and vitals. Understand the ICU environment. Familiarize yourself with all the machines and screens in the patient's room. Develop a systems-based approach towards presentation for rounds. Understand the role of commonly done procedures in ICU, and know the basics of point of care ultrasound. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from this lecture. Finally, I would love to hear your thoughts. Is there any part of this video you found particularly helpful? Is there anything I could have added to make this video more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.